Greetings. My name is Matthew L. Bush, and I'm a professor and the Vice Chair for Research in the Department of Otolaryngology, Head and Neck Surgery at the University of Kentucky in Lexington, Kentucky. I am honored to present as a part of the Florida Combined Otolaryngology meeting, and I would like to present this virtual presentation on behalf of my co-author and co-presenter for the live meeting, Dr. Jennifer Shin. I'm going to share my screen with you and get into the topic at hand, which is radiology for the hearing healthcare professional. I'm an otologist, neurotologist, and cranial-based surgeon by clinical training, and I've been pleased to call Kentucky my home over the past 12 years, where I have served here in the Department of Otolaryngology at the University of Kentucky. My co-author and co-presenter for the live meeting is Dr. Jennifer Shin. She is a professor and the chief of audiology here at the University of Kentucky in the Department of Otolaryngology, Head and Neck Surgery. These are our disclosures for this presentation. Note that the relationships described here have no conflicts of interest with the content of this presentation. I would like to send you warm greetings from the state of Kentucky. Kentucky is a whole lot more than Kentucky Fried Chicken, although it is one of our famous branding labels that is essentially found worldwide. Kentucky is famous for its bourbon whiskey. All bourbon is whiskey, but not all whiskey is bourbon. Bourbon is a unique kind of whiskey that is produced only in the United States, according to congressional rulings regarding the purity and the recipes for bourbon. It's made up of at least 51% corn. This whiskey is aged in new, charred oak barrels. It's distilled at 160 proof and barreled at 125 proof and bottled at 80 proof. And it's to be able to be called bourbon, it can't have any coloring or flavoring or additives, and all of the color and the flavor that comes from bourbon whiskey comes from those charred oak barrels. Depicted here is the holy grail of bourbon whiskeys, which is the Pappy Van Winkle family, which are quite expensive and quite elusive to the bourbon enthusiast. Central Kentucky is also home to some of the most famous racehorses in history, and it's been known as the horse capital of the world. American Pharoah and Justify are two of the most famous horses in recent horse racing history, and were born here, trained here, and have gone to pasture here after completing their racing career. Central Kentucky is also home to Big Blue Nation, which is the rabid fan base that supports the University of Kentucky Wildcats, and specifically the college basketball program is pretty famous and pretty exciting to watch. I promise not to bore you anymore with any Kentucky history or Kentucky fun facts. I do want to talk to you today about radiology and how it is useful for multidisciplinary care. We might be wondering, why do we need to study radiology and anatomy? And there's multiple reasons for why we would need to understand this, but I think it's first and foremost critical to understand anatomy before we try to understand the disease. And that leads us to then further understand the patient and the patient's symptoms. It's really important to correlate disease processes with radiology, which gives us a deeper imaging of structures that can't be visible on the outside. And the reality, when we're dealing with the lateral skull base and the temporal bone, we can't see it or touch it. Therefore, we might need to image it to be able to get some further information on what's causing the patient's symptoms. I'm hopeful by presenting this topic within this meeting, it might improve communication among disciplines, that those in audiology or speech-language pathology might have a deeper understanding and a knowledge base regarding why certain imaging studies were ordered to evaluate patients and how they can be used in the management of patients. Last but not least, we hope that knowledge can overall improve patient care. That's why we do what we do, and that's why I'm presenting to you here. Let's start the presentation with an overview of temporal bone anatomy. Most of this will be in means of review, but I'm hopeful that it serves as a meaningful refresher for you. The objectives to this section of the presentation will be to review bony landmarks of the temporal bone, describe the anatomy of the ear and the lateral skull base, and identify common sites of pathology within the temporal bone. The temporal bone is comprised of 5 bony portions, 5 bony divisions known as the squamous, the tympanic, the mastoid, the styloid, and the petrous. You can see these relative structures labeled as such. Note that there are truly only 4 portions of the temporal bone that are distinct embryologically in development. That would be the squamous, the tympanic, the styloid, and the petrous. The mastoid is actually a combination of the squamous and the petrous bone embryologically, but we often refer to the mastoid as a separate section of the bone, as it is important in surgical management of diseases of the lateral skull base. The mastoid is comprised of air cells that are contributed by the squamous bone that makes up the lateral air cell system, and the petrous bone provides the medial air cell system, and they're separated by a suture line known as the petrous squamous suture. We also refer to that shelf of bone separating the 2 segments as Kerner septum, which is an important surgical landmark during mastoid surgery. The squamous bone forms the lateral wall of the middle cranial fossa. This is bone that can be very thin in some patients, and trauma can be very significant in the lateral skull base, as it can cause disruption of vascular structures, such as the middle meningeal artery, which is just on the intracranial side of the squamous portion of the temporal bone. The temporalis muscle also sits on the surface of the squamous bone, and we often harvest temporalis fascia or connective tissue while performing a tympanoplasty. That graft material is usually ample and provides an adequate source of graft material for chronic ear surgery. The tympanic bone is the U-shaped bone that forms the majority of the external auditory canal. That is the medial 2/3 of the ear canal, and it contains the tympanic ring, which holds the tympanic membrane in place. The mastoid bone has 3 components known as the antrum, which is a window between the middle ear and the mastoid, the additus ad antrum, and Kerner's septum, which, as I mentioned before, is that remnant of a suture line between the petrous bone more medially and the squamous bone more laterally. The mastoid air cell is typically filled with air cells, and that air cell system can be developing in young children and may continue throughout early childhood. The styloid process may have less clinical significance to the hearing healthcare provider, but nevertheless, it may come up in the management of some patients. The styloid process does develop after birth, and it has attachments to several muscles within the neck. The styloid process sits on the bottom of the skull base, sort of like an eagle's talon, and you can use that imagery to connect it to a clinical condition known as Eagle syndrome, in which that styloid process may be elongated up to 30 millimeters or greater than 30 millimeters, and that can be associated with symptoms such as dysphagia or difficulty swallowing, otalgia or ear pain, and tinnitus. The petrous bone is the pyramidal shaped bone that contains the inner ear and the carotid artery, as well as the jugular bulb. So it contains some very vital neurovascular structures. The anterior landmarks of the petrous bone include the tegmen tympani, which is the thin bone that separates the middle ear and the middle cranial fossa, the arcuate eminence, which is comprised of bone that overlies the superior semicircular canal. The arcuate eminence may be missing in the clinical scenario of superior semicircular canal dehiscence. Posterior landmarks of the petrous bone include the porus acousticus internus, that is the medial most portion of the internal auditory canal, where the cochleovestibular and the facial nerve enter the internal auditory canal. The vestibular and aqueduct and the cochlear aqueduct also serve as posterior landmarks. Now let's jump into a discussion of temporal bone radiology after reviewing the temporal bone anatomy. The objectives of this section of the presentation are to discuss the purpose, process, and indications of CT scan imaging, and CT is short for computed tomography. We will examine normal CT anatomy of the temporal bone and cranial base, and discuss the purpose, process, and indications of MRI, which stands for magnetic resonance imaging, and then we'll examine normal MRI anatomy of the temporal bone and lateral skull base as well. Let's first talk about computed tomography or CT scan imaging. This type of imaging modality is non-invasive, and it utilizes ionizing radiation or X-rays to produce a diagnostic image. These images can be used to delineate the anatomy and may draw inferences regarding function of those relative structures. The process of obtaining a CT scan is somewhat complicated, but in a general sense, radiation is emitted from a transmitter, as shown in this picture here on the right by the small green arrow, and that radiation travels across the opening of the CT scanner, which is like a large donut, the patient being in the center, positioned essentially where the X is located on the picture. Different tissues allow transmission of radiation waves at different rates and to different degrees, and the relative radiation that travels through the patient is then picked up by the detector shown by this long green arrow. And then the computer system of the CT scanner is going to interpret all of that information, the rate of radiation that's transmitted through different tissues, and it's going to then produce pictures that help us to see the anatomy. The advantages of a CT scanner is that a CT can be obtained in a very short time period. It takes only a few seconds to perform a CT scan of the temporal bone, for example. It's non-invasive. It doesn't require any needle sticks necessarily. It doesn't require that a patient has to have contrast. And it can be very sensitive to evaluate anatomy, specifically bony anatomy. And we might want to evaluate bony anatomy in the setting of trauma or congenital malformations, or perhaps preoperatively before chronic ear surgery or before cochlear implantation. CT scan imaging can be used very quickly as a screening modality, even can be used in children. However, we do need to be careful about radiation exposure in children and certainly radiation exposure in pregnant patients. The disadvantage of a CT scanner is that, yes, indeed, it does involve ionizing radiation, and because of that, we have to be careful of exposures for vulnerable populations, such as children or pregnant patients. We also have very poor soft tissue delineation or definition with a CT scanner. You can use IV dye or contrast, which does contain iodine in that setting. The IV contrast can be used to evaluate infectious or neoplastic disease, such as tumors, but there is a pretty significant incidence of contrast allergy because of that iodine that's used in the dye. Unfortunately, CT scan imaging is a very poor diagnostic tool to evaluate lesions of the internal auditory canal, such as a vestibular schwannoma. The indications for usage of a CT scanner, again, as I mentioned, might be bony disease involving the temporal bone, such as trauma. Here's a representative CT scan of a temporal bone, which demonstrates in the white arrows fracture lines in the setting of blunt trauma. Superior semicircular canal dehiscence, as I mentioned before, the absence of that arcuate eminence within the middle cranial fossa might result in a dehiscence shown there in the scan to the right. Next, osteodystrophic disease or disease of the bone itself primarily, such as shown here in fibrous dysplasia, showing this ground glass appearance of bone throughout the skull. We also could utilize CT scans to evaluate cochleovestibular malformations, such as a Mondini deformity shown here on this CT scan. We can also evaluate complications of otitis media, such as a fistula of the horizontal semicircular canal or the labyrinth, or destruction or damage of the mastoid, known as mastoiditis, caused by a chronic ear infection. And this is an example of coalescent mastoiditis on this particular CT scan. We can also evaluate intracranial abscesses and destruction of bone that allows direct transmission of infected debris into the intracranial cavity. We can also evaluate the internal auditory canal, although not ideally, but we can use it in this scenario where MRI is contraindicated. Now I'm going to take you through some CT scan images, which are going to focus a little bit more on the bony detail, and we're going to use images known as an axial orientation. And that will be a cross-section through the head, and I'll orient you here to this particular viewpoint. In this particular view, the bottom part of the screen is the back of the head. The top part of the screen is going to represent the front or the anterior towards the nose. The orientation is that the patient's laying on the table with the feet coming towards us. So the right ear is actually on the left side of the screen, and the left ear is on the right side of the screen. And this is by convention. This is how axial scans are typically set up. You can see that on a CT scan, air in the room is black that surrounds the patient, bone is white, and then everything else is some shade of gray. It could be skin or muscle or brain or cerebrospinal fluid in this particular window of the CT scan. And so we're primarily looking at bony anatomy in this situation. You can see that we're going to label the structures along the way. On the left mastoid, you can see the mastoid air cells, which are black. There are little webbing of mastoid air cells that actually are white of the delicate bony anatomy within the mastoid. You can see as we progress from superior to inferior, you're seeing more of these mastoid air cells within the left mastoid cavity. You now can see the sigmoid sinus, which is going to drain blood from the venous system from the sagittal sinus and the transverse sinus down into the lower skull base and help form the jugular bulb inferiorly. As we progress again through the mastoid, we are now seeing very dense otic capsule bone more medially, and I've labeled where the superior semicircular canal is located. You can see that little lumen inside of and near the point of this red arrow showing us the lumen of the superior semicircular canal. Note how the bone of the otic capsule is much denser and it thus has a brighter white appearance on this CT scan image. You can see how the semicircular canal, superior semicircular canal, is separating there to the separate crura. And as we move further inferiorly, we're beginning to see a vessel known as the subarcuate artery that is going to travel right in between the crura of the superior semicircular canal. At this level, we're also seeing the posterior semicircular canal and its lumen demonstrated near the point of the arrow right along the pointer here. As I move further inferiorly, we're now going to see the horizontal semicircular canal demonstrated, again encased in very dense otic capsule bone, and then the petrous apex more anteriorly, which is going to contain more air cells. The vestibular aqueduct would sit at this approximate level. At this point, we are now seeing the internal auditory canal where the vestibulocochlear nerve travels from the lateral side of the brainstem. We also see at this level the incudomalleolar joint, or the IM joint. It almost looks a little bit like an ice cream cone, where the ice cream represents the head of the malleus and the cone is the short process of the incus. Looking back at the internal auditory canal, you can see labeled CN7, or cranial nerve 7. That's the facial nerve that is exiting the lateral aspect of the internal auditory canal and begins its journey through the fallopian canal. That's the bony canal within the temporal bone that's going to transmit the facial nerve. As we progress, you'll see posteriorly a structure labeled as the mastoid emissary vein. This is an additional vein that may emanate from the sagittal, the sigmoid sinus, and may travel through the bone and be found under the skin, and actually may be a source of bleeding during mastoid surgery. At this level, we're beginning to see the cochlea, which I have labeled here with a red arrow. And you can see that the cochlea has as we follow, you'll see that it has several turns in which its spiral-shaped structure will be followed through the imaging. Similarly, at this level, we're starting to see some important middle ear structures, specifically the IS joint, the junction of the long process of the incus, joining with the head of the stapes. And we see at this level around just deeper here in the middle ear is the oval window. And then more posteriorly, the sinus tympani, which is just tucked up underneath the facial nerve. It's a common place for cholesteatoma to hide in chronic ear surgery. Seeing more of the same structures demonstrated here. And as we move on, we're now beginning to see the round window niche, or the RW niche, listed here. That is the location point where most cochlear implants are performed, and we'll access this particular area through the mastoid posteriorly during cochlear implant surgery. And you can see that on the other side of the round window is the basal turn of the cochlea. At about this level, you see a portion of the tympanic membrane, although it's very faint. I realize that. This is a normal tympanic membrane. A diseased tympanic membrane often can be thickened and is much more visible on CT scan imaging. The facial nerve at this point is encased in bone in its mastoid segment. And much anterior here, adjacent to the petrous apex, you're going to see the carotid artery and its vertical segment. Carotid artery is then going to form the horizontal segment adjacent to the eustachian tube. And you see that orientation of the carotid artery traveling in this orientation, and then the eustachian tube opening within the middle ear is going to transmit, connect air from the nasopharynx to the middle ear space. As we move further inferior, I would encourage you to kind of keep your eyes locked on where that cranial nerve 7 is listed or shown here. It's going to be adjacent to the jugular bulb inferiorly. Note the orientation of the carotid artery is more anterior and the jugular bulb is more posterior. Now we see this vertical segment of the carotid artery, which as it travels up through the neck, that's the vertical segment, and it's going to make a right angle turn, and it's going to form the horizontal segment and then travel further intracranial. As you follow that cranial nerve 7, you're going to see it leave the skull base here at this, adjacent to the styloid process, through an opening known as the stylomastoid foramen. Okay, that was a quick overview of CT scan anatomy. Let's now talk about MRI imaging. This is a non-invasive imaging modality which utilizes high-power magnetic fields to produce a diagnostic imaging, and it's used similar to CAT scan to help us delineate anatomy and draw inferences regarding function. The physics behind how an MRI works is complicated, and we'll not have a quiz on this, I promise you, but an MRI specifically involves a very high power, always on magnet. And that magnetic field is produced by sending electricity through wire coils that otherwise would be overheated and cause an immense amount of heat. But those wires are cooled to negative 452 degrees with liquid helium, actually. And that cooling allows this to stay stable and useful for MRI imaging, but allows for a stable magnetic field. There's then smaller magnets that will alter their field periodically. And what this does is it manipulates hydrogen ions within tissues, which has different tissues have different characteristics of their hydrogen ions, which allows this emission of energy, which is picked up by sensors adjacent to the patient. So it has to be these sensors, which are detecting very small changes of hydrogen ion activity, have to be very, very close to the patient. Thus, it requires an MRI scanner to be very, very narrow. This can produce different kinds of images. Specifically, we often look at T1 images versus T2 images. It's just two different kinds of images based on tissue behaviors and characteristics. On a T1 image, which is shown here to the right, you see an axial view, similar to those axial views of a CT scan, but note in this situation that fat under the skin is bright white, or fat that surrounds the eyeballs and the orbit is bright white. Bone is actually black on a CT, on an MRI scan like this, and CSF or spinal fluid is usually dark in this particular situation as well. In a T2 sequence, fluid is typically bright and fat is not quite as bright as the fluid. So water or fluid containing structures are bright white on T2 imaging typically. Fat bright on T1, fluid brighter on T2. Why might we use an MRI? Well, we might use it to evaluate disease of the central nervous system, such as infarcts or tumors. A CAT scan is not indicated for some patients that may have a hemorrhagic stroke, and an MRI can be used in that setting. We can use contrast a little bit more safely in MRIs because it does not involve iodine, so there's a much lower incidence of contrast allergy. We might evaluate lesions of the skull base that might have soft tissue involvement or destruction or involve nerves nearby. A malignant otitis externa is a very aggressive form of an infection within the bone that begins in the external auditory canal and may spread throughout the skull base. And the MRI is an ideal study to evaluate this type of infection. Furthermore, we might evaluate muscles or joints such as the temporomandibular joint through MRI imaging. The advantages of MRIs is that it can provide excellent soft tissue distinction and delineation. It does not involve any ionizing radiation or X-ray, so it's safe for children, it's safe for pregnant patients. These image slices and image orientation can be manipulated through the computer to reconstruct a variety of different views of tissue. And as I mentioned before, the IV dye contrast has a much lower incidence of allergy problems. The disadvantage is that because of that close nature of the sensors to detect these hydrogen ion movements and energy changes, it's a very, very tight space. And so claustrophobic patients may be miserable and unable to tolerate a scan. Because of the strong magnetic field, it also might not be safe for those with older versions of cochlear implants, or those with aneurysm clips or pacemakers or other metal foreign bodies. It takes a long time also to get an MRI scan, so that's also a disadvantage. It can take anywhere from 20 minutes up to 90 minutes to get an MRI scan, and patients have to hold very, very still or the image quality will be degraded severely. Additionally, it's a very poor definition of the bone anatomy. So trauma or destruction of bone is not adequately visualized with MRI imaging alone. Okay, similar to how we did the CAT scan imaging, let's go through an MRI scan. This is an example of a T1 sequence axial view that does not have any contrast. You'll note that this is a similar orientation, but you'll see bright white under the skin. That's not bone. That's actually fat under the skin. You'll see that the mastoid air cells on the right side are labeled here with a red arrow, and that's actually black. You don't see any detail, unlike that CAT scan that I showed you. The vertebral arteries are outlined here with the red arrows, and you actually see some white in there, and that actually might be calcification inside of the vertebral artery that makes it appear white like that. This is adjacent to the brainstem. At this point, you're starting to see the sigmoid sinus on the right side. It's only just a hue. You don't really see much of that sinus. There's no contrast within those vessels, and so you don't see that sigmoid adequately. Those vertebral arteries are going to come from the side of the brainstem and converge to form the basilar artery in the anterior face of the brainstem. We're beginning to see the carotid artery at this point as well. And look at the white that's in the carotid. That's some calcifications that may be represented inside of the carotid. At this level, we're seeing the cochlea and the vestibule, as well as the internal auditory canal. Notice that you just, again, don't see much of the detail of the nerves themselves on this particular view. We often use contrast that would make a vestibular schwannoma in this region appear bright white. The cochlea and the vestibule, we only see a hue. We don't really see much of specific detail within the bone. At this level, we would see the fifth cranial nerve, or the trigeminal nerve, emanating from the brainstem. Moving further superior, lastly, you see that carotid artery or that carotid siphon as it has headed further intracranial. Okay, now let's look at the other type of image, not the T1, but the T2. And in this particular image, you can see fat still under the skin. Notice that the bony anatomy is still black, but CSF or spinal fluid is very bright white. It's very intense in brightness. And you can see the vertebral artery floating within this pool of CSF around the brainstem. I'll show you general locations of certain nuclei that might have clinical significance for central pathology, such as the sensory nucleus of the vagus nerve or the hypoglossal nucleus. We can see where the hypoglossal nerve essentially would be in that particular location adjacent to the brainstem. And at this point, we're now going to see the inferior cerebellar peduncle. And now you see where the vagus nerve, or the 10th cranial nerve, is exiting the side of the brainstem, headed into the jugular foramen and out of the skull base. The inferior vestibular nucleus would be located in this general location. This would be the level of the 7th cranial nerve nucleus and the superior vestibular nuclei adjacent to it, and the superior olivary nuclei. At this point, we're now seeing the internal auditory canal. And notice how that CSF goes into the bony internal auditory canal, which is, the bone is black, but the fluid is bright white. And you can actually see the nerve structures of 7th and 8th cranial nerves floating within that CSF. You also see fluid within the cochlea and the vestibular structures as well. So this can be a very helpful scan, and T2 specifically for preoperative evaluation for cochlear implantation. You're seeing some other structures such as the middle cerebellar peduncle and the other vestibular nuclei. This is where the 5th motor nucleus would be, adjacent to the 4th ventricle. Spinothalamic tract, superior cerebellar peduncle are in this location. You can see the 5th cranial nerve emanating from the brainstem headed anteriorly. This is the location of the medial longitudinal fasciculus. The trochlear nuclei. Now we're at the level of the occipital lobe posteriorly and the temporal lobe laterally. Now we would be in the general vicinity of the oculomotor nucleus and then the oculomotor nerve. At this point, we would be adjacent to and near the optic chiasm and the middle cerebral artery. We're now seeing the sylvian fissure here on the left side, where we might find Broca's area adjacent to, along with the 3rd ventricle. More posteriorly within the temporal lobe, we see the Wernicke's area, and the frontal lobe shown more anterior. The posterior occipital lobe is labeled here, and now we see the ventricles and the parietal lobe adjacent to it. Okay, that's a whirlwind tour of intracranial anatomy, and now you're experts in neuroradiology. So let's talk a little bit now about neurootologic pathology. I'm going to present a variety of lesions and pathology of the temporal bone and lateral skull base, and we'll discuss important features of clinical presentation in neuroaudiologic disease. And I'll present pertinent imaging studies used in the diagnosis of neuroaudiologic disease. Here's some of the pathology that we'll discuss: temporal bone trauma, congenital anomalies, complications of otitis media, osteodystrophy of the temporal bone, and tumors or lesions of the skull base. First of all, let's talk about temporal bone trauma. 20% of all skull fractures involve the temporal bone. It does require an incredible amount of force to fracture a temporal bone. These fractures most commonly occur in younger patients during their 2nd to 4th decades, typically involve men doing risky things or involved in risky activities. Men are 3 to 4 times more susceptible to temporal bone fractures than women. Motor vehicle accidents are the #1 cause in the United States, but also assaults or falls, motorcycle accidents, bicycle accidents, and gunshot wounds can be a culprit for temporal bone fractures. We classify these temporal bone fractures based on whether they traverse or destroy the otic capsule bone or not. So otic capsule sparing versus otic capsule disrupting fractures. And of course, since we're trying to look at bony anatomy, the CT scan is critical in making that determination. Here's a case study in which a 14-year-old was involved as a gunshot wound victim to the right face and experienced complete sensorineural hearing loss, and the bullet fragment actually lodged within the within the right mastoid. You can see on the CT scan image in the middle the fragmentation of the bone with that bullet fragment, which is very bright white. And this patient had normal facial nerve anatomy with extensive soft tissue destruction. So surgery was performed with a mastoidectomy to remove the bullet fragment and then remove all of the infected and destroyed debris, remove all of the skin, and close off the ear canal. Congenital anomalies are also evaluated often through CT scan imaging. Oral atresia is one such example, as shown here in the CT scan with the yellow arrow demonstrating that there is no ear canal that actually opened. This can occur in 1 out of 1,000 live births and is associated with facial nerve, ossicular, and craniofacial anomalies. We typically use the CT scan imaging to help to grade the severity of the atresia and to determine the likelihood of benefit from surgical intervention. One such grading scale is the Jarsdorfer scale. Here's an example of an anomaly of the inner ear known as Mondini deformity, shown at the end of the pointer here with the yellow pointer or yellow arrow. Mondini deformity is associated with a 1.5 turns of the cochlea instead of the usual 2.5 turns. It's associated with a higher risk of CSF leak during inner ear surgery, such as cochlear implantation. Certainly, it is possible to have a normal cochlea radiographically and have yet a congenital anomaly known as Scheib's dysplasia, which is a membranous dysplasia where the bone actually appears normal. But a Mondini deformity usually can be quite visible through a CT scan. Here's another view of a Mondini deformity. Notice how the basal turn looks normal, but the second and third turn or half turn more apically seem somewhat fused. So we would call this a 1.5 turn cochlea with a Mondini deformity. Here's a very rare anomaly known as Michel's aplasia. The yellow arrow is basically pointing to the space where the cochlea should be, but there's actually no cochlea that formed. This is less than 1% of all cochlear anomalies. This is a setting of complete atretic or lack of formation of the cochlea or agenesis. You may see a small cystic area of the AUD capsule, but in this situation, cochlear implantation is contraindicated. Now let's talk a little bit about complications of otitis media. Here's an example on this coronal view where we can see the ear canal and pointed out with the white arrow is cholesteatoma that's between the malleus more medially and the ear canal more laterally. Cholesteatoma, of course, is epithelial lined pocket of skin that can collect debris and bacteria. It can cause bony erosion or destruction of the ossicles or other temporal bone structures. We often use CT scan imaging to evaluate the bony destruction caused by cholesteatoma. We can also see whether the horizontal semicircular canal is intact in the setting of cholesteatoma. Here's another example, which I showed a picture of this earlier, but the red arrow on the CT scan on the right is showing a destruction of that fine lattice-like architecture of mastoid air cells into one cavity that was caused by an infection. This is a form of mastoiditis called coalescent mastoiditis, where all the fluid or pus and infected debris coalesce within one cavity. And this particular patient also showed on a CAT scan inferiorly, or excuse me, this is a scan more inferiorly with this MRI scan. You can see a large abscess within the posterior fossa adjacent to the cerebellum. So we can evaluate these types of complications with not only CT scan, but if we have further intracranial pathology like this abscess, we may choose to do an MRI scan as well. Our CT scan imaging is also helpful to show us changes or abnormalities of the bone. Fibrous dysplasia is an abnormality in how the bone forms and develops, and it gives this ground glass appearance shown by the middle CT scan here. That bone just looks different than the other CT scans that we've looked at. The Paget's disease looks like a moth-eaten or multiple holes throughout the bone. Sometimes we call it a mosaic pattern. That's shown on the CT scan to the right. Other bony disease like osteogenesis imperfecta can also be evaluated through CT scan imaging. Now let's talk about tumors of the cerebellopontine angle. Vestibular schwannomas are the most common lesion of the internal auditory canal. Typically involves the vestibular component of the vestibulocochlear nerve. and typically will present with asymmetric sensorineural hearing loss, tinnitus, and vertigo. MRI, specifically the T1 sequence with contrast, is the study that we typically use, and that's what's shown here on this MRI image to the right. You can see that the yellow arrow points at this whitish structure. That's the tumor itself emanating from the vestibulocochlear nerve. I'll show you a series of different images here. This is another picture of a cranial nerve schwannoma, like a vestibular schwannoma. You can see that there's different imaging characteristics based on what type of imaging modality that you're using. But again, that MRI with contrast, T1 with contrast, is the sequence we're looking for. Look at this very large tumor. It's actually compressing the brainstem on this picture to the left. And then this is another T1 with contrast showing the vestibular schwannoma on the right as well. That tumor is bright white in appearance. And if it didn't have contrast, that tumor would appear dark, similar to the same appearance of the brain tissue itself. Here's another type of cranial nerve schwannoma shown on the right side with a facial nerve schwannoma in this particular setting. Just a smaller tumor, also appears bright white. And look how if you use the T2 sequence, you can actually see that it's not bright, but it's a dark structure that's filling that void within the internal auditory canal where normally it would be filled with CSF. Here's an example of that same tumor that I showed you on the first slide, that large schwannoma. And after it's been removed through a translabyrinthine craniectomy with removal of the tumor, and then the wound was packed with abdominal fat to close off that space and prevent CSF leak. You can see how the brainstem is starting to relax and release from its pressure, and that fat is in position to prevent spinal fluid leaking. So MRI imaging is used preoperatively, but also postoperatively to show us if we've removed all of the tumor, for example. Here's another example of a schwannoma. This is a seventh nerve schwannoma in which the arrows are showing the course of the facial nerve, which are brightly enhancing, indicating a schwannoma of the facial nerve. Another common tumor of the cerebellopontine angle is a meningioma, which is very common, has a very similar appearance on MRI imaging. It's usually brightly enhancing, and it may have a dural tail or edges in which the lesion itself, which emanates from the dura or the lining of the brain, can have a base on that dura and a flat surface. Here's a view of it with the T1 with contrast. The lesion is here on the right side, and it's outlined here with brightness of the dura adjacent to the tumor, like little tails extending from the tumor. This is an example of a paraganglioma or a glomus tumor, such as a glomus jugulare tumor. It's shown on the right side, on the left side. The CT scan is shown here on the left, and you'll see that there's bony destruction pointed to by these white arrows. And on the MRI imaging to the right, you can see how this brightly enhances, and we see blood vessels, which are these dark spots within the tumor. It's like a void where blood is traveling through, and there's no picture there, so it's a void within the tumor. So some people say that it has a salt and pepper appearance, a bright whiteness to it, as well as dark spots throughout. These are some unique characteristics to paragangliomas or glomus tumors. This is an example of an endolymphatic sac tumor, which is a not exceedingly common tumor that can occur within the lateral skull base, that can appear bright white on T1 with contrast, and can show then some bony destruction around the skull base. And notice that there's also a brightness on T2 as well. The MRI scan to the right shows that a tumor on the left side has a bright white appearance to it, and that's characteristic of an endolymphatic sac tumor. Here's a metastatic lesion that's shown here on CT scan imaging on the left. This particular image shows that in a right temporal bone, there is a bony destruction of the petrous bone and the internal auditory canal. This was a renal cell carcinoma that had metastasized to the temporal bone. Patients may also have swelling or edema present within the brain if it involves the brain parenchyma or tissue adjacent to it, and that's what this MRI, the T2 sequence on the right, demonstrates. Here's an interesting situation of a patient who had a cholesteatoma. Cholesteatoma appears typically darker on T1 and brighter on T2. And then when you do a CAT scan, you might see bony erosion or destruction. You can see that this is the same general orientation on the same patient, where you've got a CT scan showing expansion of cholesteatoma here on the left. The next image shows the T1, which the lesion is really not bright. You don't see much of it. And then the T2 sequence adjacent to that, and you actually see some whiteness in that area. And so it's bright white there. And there's a specific type of MRI sequence where fluid will appear dark, yet cholesteatoma will appear bright. That's called diffusion weighted imaging, or DWI. It can be used to screen for recurrence of cholesteatoma. And that's the image shown here to the far right. That bright whiteness in the center represents the cholesteatoma in this skull base. Cholesterol granuloma is an expansile lesion within the temporal bone that can cause auditory and vestibular symptoms. And you can see this leftmost picture shows a CT scan showing an expansion, almost like an eggshell thin bone encasing this cystic-like structure. This particular structure on MRI imaging, though, appears bright on T1 and bright on T2. So how these tumors or lesions appear on MRI and CT help you to get the information on what type of lesion or what type of tumor you're dealing with. This is a cyst that's extending into the sphenoid sinus more anteriorly, and actually might be the surgical approach to drain this lesion, not through the ear, but actually through transnasal or through the nasal cavity. All right, let's, for the last few moments of our presentation, let's go over some neurootologic case studies. I'm going to give you some scenarios in which there's some different clinical scenarios, and consider some of the clinical questions that we might ask and how we might evaluate these patients. The objectives during this portion of the presentation are to review the presentation and clinical findings of patients with otological disease, determine radiographic studies that might be useful in the disease management or diagnosis, and then we'll review the radiographic studies and the anatomy of the temporal bone and lateral skull base connected to that, and then consider a treatment plan based on this data that I present. The first case is a 69-year-old male with a history of progressive left hearing loss over 20 years. He has mild tinnitus on the left side, which isn't exceptionally bothersome. He has mild imbalance, but no vertigo. He has trouble in noise localization because of this asymmetric hearing loss, which you can see is an asymmetric left sensory neural hearing loss. Note his word discrimination, which is 96% in the right ear and 8% in the left ear. It's interesting that there is a discrepancy between the degree of hearing loss, which is not severe, and his word recognition on the left side, which is disproportionately or unexpectedly much lower than one might expect. So we would ask ourselves, in the setting of an asymmetric sensory hearing loss, what type of condition are we concerned about? What type of imaging study might we perform? And if we would use an imaging study, whether we would use contrast or not. So in this situation with asymmetric sensory hearing loss, we're worried about retrocochlear pathology, such as a vestibular schwannoma. And in that situation, we might want to perform an MRI scan, a T1 with contrast, specifically as our gold standard test to evaluate for vestibular schwannoma or other retrocochlear pathology. And indeed, in this situation, the patient received the MRI scan, and lo and behold, you see pointed to by this red arrow a vestibular schwannoma on the left side that's the culprit for this asymmetric sensory neural hearing loss. So in this situation, we might ask ourselves, what are the treatment options for a tumor such as this? So we could consider observation based on the size of the tumor. We might determine if it's a small or medium-sized tumor, perhaps to observe the tumor. Or again, if it's small or medium-sized, less than 2.5 centimeters, we might consider radiation as a treatment option with either gamma knife radiotherapy or cyberknife radiation. Or thirdly, we might consider surgical resection through a variety of different approaches. Now, this patient doesn't have that much functional hearing, and considering the size of the tumor, hearing preservation surgery is not likely an option. But again, based on the size, the location of a tumor will guide and direct the surgical team to consider which surgical approach might be best. What are hearing loss treatment options here? Well, with this asymmetric sensory hearing loss, we could consider a cross aid, for example, as one option. We could also consider bone conduction technology, such as a bone conducting hearing aid. We also could consider, in some situations of non-growing vestibular schwannomas, could consider a cochlear implant. Now, that size of the tumor was considerable and might require surgical intervention. So one would want to make sure that this tumor is not growing, is very, very stable before considering surgical intervention. Historically, we've ruled out cochlear implantation for those with retrocochlear pathology, but now there's pretty reasonable evidence that's demonstrating a benefit for patients that get a cochlear implant in an ear that has a non-growing, relatively stable vestibular schwannoma. Let's move on to another case. In this situation, we have a 50-year-old healthy female who was involved in a motor vehicle accident. She suffered loss of consciousness and noticed bilateral hearing loss upon awakening. She subsequently also reported tinnitus in both ears, but was significantly worse in the left. The right side gradually improved, and she was then able to get, after she was stabilized and treated for the trauma, able to get an audiogram which demonstrates a mixed hearing loss with a pretty significant airbone gap on the left side. Note that her word understanding or word recognition is normal in both ears. In this situation of trauma, what might we be considering as far as what's the culprit or the cause of her hearing loss? What type of imaging study might we consider? And should we use contrast or not? So, considering it's a traumatic accident, we're worried about bony fractures, bony disruptions, so we need to get a CT scan, not an MRI scan. And indeed, this patient had a CT scan. And note, it's shown by this red circle on this left side. She has disruption of that ice cream cone, that incudo-malleolar joint. The malleus is the ice cream. The cone is the short process of the incus. And she has disruption of that joint, which would be the culprit for a conductive hearing loss. I'm showing you a blown up view of that very same scan, demonstrating that the ice cream has fallen off of the cone. So in this situation, what are our treatment options for the injury? Well, in the acute setting, we often just want to observe and that the patient may have blood within the middle ear space, and we want to let that resolve. And furthermore, ossicular discontinuity can correct itself given time. And so we may wait anywhere from 3 to 6 months to allow ossicular discontinuity or disarticulation to refix. If this hearing loss is persistent beyond that, then we may consider surgical exploration with ossicular reconstruction. Certainly for other hearing options that we can consider, I don't think we likely would recommend much for the right side other than just observation. If the patient is bothered by this mild low frequency conductive loss on the right side, a hearing aid could be considered, and also non-surgical options for the patient for the left would also include a hearing aid as well. Okay, let's move on to another case. In this situation, we've got a 14-year-old male with 6-month history of gradual, very gradual left-sided hearing loss and tinnitus, no vertigo, no history of otologic surgery or infections or trauma. The patient's mother and sister do have a history of vestibular schwannoma. There is also a history in the family of juvenile cataracts. The patient has a essentially normal exam. The tuning fork examination demonstrates and confirms the audiologic findings shown here to the right, which demonstrates an asymmetric left sensory hearing loss with 0% word discrimination or recognition on that side. So again, I'll ask you the same questions. What condition are we concerned about, and what type of imaging studies would we consider, and should we use contrast or not? We're worried about, in this situation of an asymmetric sensory hearing loss and tinnitus, we're worried about retrocochlear pathology. Note this patient has a strong family history of schwannoma, and so we're worried about neurofibromatosis type 2 or NF2. And again, we would want contrast. MRI with a T1 sequence with contrast is going to tell us for sure whether there's a vestibular schwannoma or not. And lo and behold, this MRI scan shown on the left with the 2 red arrows show you dueling vestibular schwannomas. Note the patient only has hearing loss on one side, but he has bilateral vestibular schwannomas. And he also has multiple meningiomas as well. So this is a terrible disease, and so it's a complex management of a young patient with vestibular schwannomas. We can consider surgical resection. We might consider decompression of the internal auditory canal to perhaps take some pressure off the vestibulocochlear nerve complex. So this is definitely going to require multidisciplinary care. We certainly don't have any drug therapy that has been widely used in the NF2 population, but there's a lot of research that's been conducted in this population. Hearing loss treatment options, we might consider a cross hearing aid. We might consider a bone conduction device as well, but in most situations, a 14-year-old might be poorly compliant, and so may not choose to pursue any treatment at this point. Moving on to another case, we'll talk now about a 2-year-old female with speech delay, a history of failed newborn hearing screen, and a failed follow-up ABR. She has normal external ear anatomy, normal tympanometry and middle ear exam, no family history of disease. What kind of condition are we concerned about in this situation? What type of imaging study might we consider? And should we use contrast or not? Well, we're talking about a congenital ear, and so the biggest bang for our buck and the most helpful thing to look for normal presence of vestibular cochlear nerve anatomy would actually be to do an MRI scan, although many people might choose to do a CT scan. So this patient had an MRI scan which demonstrates normal vestibulocochlear nerves as well as normal cochlear anatomy. She had a CT scan as well in this situation, which shows normal cochlear anatomy. So these are some of the preoperative imagings that one might obtain prior to cochlear implantation. Again, what are the treatment options for that type of patient? Well, we certainly would consider cochlear implantation of this child who's already delayed in language development and a little delayed in the actual treatment of her sensorineural hearing loss. Our fifth case involves a 28-year-old male with gradual progressive congenital loss. He's an oral communicator, and he's a compliant hearing aid user. He states that he wants to advance his career, wants to have his hearing improved. Notice that he has very poor word recognition of 10% bilaterally, and you see his sloping sensorineural hearing loss, which is pretty significant. What condition are we concerned about in this situation, and what imaging study might need to be performed, and should we use contrast or not? Well, in this situation, you could consider an MRI scan or a CT scan. In this situation, he obtained a CT scan that was not contrasted because we want to look at the bone anatomy, and we actually see the situation of an enlarged vestibular aqueduct here. You can see those pointed to with a red arrow. And that particular patient also had a Mondini deformity as well. So what are our treatment options in this particular situation? Well, we would proceed with cochlear implantation, most likely in this situation, based on his poor hearing. Granted, we would need to perform a definitive cochlear implant evaluation with sentence testing. Our sixth case involves an 18-year-old male who was involved in altercation and was struck in the back of the head. He had loss of consciousness and experienced right sudden hearing loss and vertigo. He has no family history of hearing loss and is otherwise healthy. His examination is normal on the otoscopic examination. However, on the tuning fork examination, the tuning fork lateralizes to the left ear, and you can see on his audiogram here to the right that he has normal hearing on the left, but profound sensorineural hearing loss on the right with no discernible word discrimination on the right. Again, what condition are we concerned about? What type of imaging would we want to perform? And should we consider contrast or not? We're looking for some destruction or disruption of the otic capsule because of this traumatic event, and we would want to perform a CT scan. And sure enough, he's had shown by this red arrow here on the CT scan imaging a fracture line or a fault line traveling right through the cochlea. This is an otic capsule disrupting fracture that has resulted in profound sensorineural hearing loss and vertigo in this situation. So what study might we want to consider? Well, if in the acute phase, we won't necessarily need to perform an MRI scan, but we may want to rule out retrocochlear pathology potentially. It's very unlikely considering his history of sensorineural of trauma, but in the long term, we may want to perform an MRI scan just to make sure that he hasn't had fibrosis or destruction of the cochlea, because fractures can induce a fibrotic or inflammatory reaction. So we also consider in this differential diagnosis a labyrinthine concussion if there was no fracture found, or a perilymphatic fistula. In this situation, though, this is clearly a temporal bone fracture. And what are our treatment options in this situation? Well, this might be an ideal candidate for a cochlear implant for single-sided deafness, assuming that he undergoes the diagnostic testing for cochlear implant candidacy. This is our last case, and this represents a 56-year-old male with a history of progressive hearing loss. He has no history of trauma or infections or surgery. He has 2 sisters with a history of hearing loss. In this situation, you can see the left-sided sensorineural hearing loss, which is mostly sensorineural. There's maybe a small conductive component in this mixed loss. However, he's got a very stark, clear mixed hearing loss pattern in his right ear. Note that his word discrimination is very functional here, 84% and 92%. I'll ask you here again the same question: what condition are we concerned about? What imaging study might we consider? And should we use contrast or not? In this situation with a family history of hearing loss and a significant conductive component, we're worried about something to do with the ossicular chain. In this situation, we might be concerned about otosclerosis. And a CAT scan here in this situation shows us the cochlea, but this rim of bone that's changed around the cochlea. And this is a representative image of cochlear otosclerosis that you can see on CT scan imaging. You may consider an MRI scan as well. And in that situation, that bone would often be very bright enhancing because it's very vascular bone that's turning over and changing the anatomy of the cochlea. And when we consider treatment options, this patient doesn't need a cochlear implant because of the very functional word recognition. This is a patient that will likely benefit from the stapedotomy procedure and removal and replacement of the stapes. However, non-surgical options could include traditional hearing aid amplification in both ears. Note that the left ear would not likely be a surgical candidate based on the degree of hearing loss, or the conductive hearing loss component to that mixed loss. Okay, that concludes our case series and case study, as well as the overall presentation. I really want to thank you for your time and attention, and I welcome you to email me with questions or concerns. I hope you have a great day and enjoy the rest of the conference.